High blood pressure operates with silent precision. While a patient feels perfectly normal, immense mechanical force systematically dismantles the body's microarchitecture. The cardiovascular system absorbs this force for years, but the primary casualty is often found elsewhere. The kinetic energy of systemic hypertension eventually destroys the renal anatomy. To understand why, we have to look at the kidney's basic structural unit, the nephron. A single human kidney houses roughly 1 million of these individual filtration plants, tasked with clearing toxins from the blood. Every nephron contains a specialized capillary filter called the glomerulus. This microscopic mesh physically separates waste from the bloodstream. When blood pressure stays elevated, it triggers a 6-step biomechanical cascade that destroys this filter. We will map exactly how that mechanical collapse happens and pinpoint the specific nodes where homeopathic therapeutics intervene. 1 million individual filters eventually succumb to the relentless accumulation of pressure, making kidney failure a predictable mechanical collapse. Systemic hypertension translates directly into high intraglomerular pressure, forcing blood through these delicate capillary networks with dangerously high turbulence. Look at this developing flowchart. That continuous mechanical stress physically batters the capillaries, causing direct trauma to the endothelial lining. The high velocity strips away the vessel's protective inner layer. This injury causes a biochemical crisis. It depletes nitric oxide in the local environment, forcing the surrounding blood vessels to stiffen and constrict. The pipes are becoming rigid. The damaged glomeruli attempt to heal themselves by laying down thick scar tissue, a process called glomerulosclerosis, which encases the delicate mesh in rigid biological cement. Because the filter is now buried under scar tissue, the functional filtration capacity of that specific nephron drops significantly. The mesh is essentially plugged. At this stage, the pathology is entirely structural. The patient feels zero symptoms, even as thousands of nephrons are systematically taken offline. As the pressure continues to rise against these blocked filters, the remaining capillary walls rupture, forcing large molecules like proteins directly into the urine stream. This leakage, called proteinuria, is the critical early warning sign. It is the first macroscopic proof that the microscopic architecture is failing. As individual nephrons die off entirely, the remaining healthy units must hyperfiltrate to compensate. They absorb the entire filtration load of the dead units, accelerating their own destruction. This leads to chronic kidney disease. The overall glomerular filtration rate plummets due to mass nephron burnout, while systemic toxin levels scale inversely. Without functioning filters, toxins accumulate rapidly in the bloodstream. This progresses directly into advanced uremia, ultimately forcing the patient to rely on mechanical dialysis to survive. The kidney's architecture is destroyed by a domino effect. The mechanical failure of one nephron places unbearable strain on its neighbor, guaranteeing its collapse. As filtration capacity drops, the kidney misinterprets the localized drop in pressure as a sign that the entire body is hemorrhaging. To save a body it thinks is dying, the damaged kidney releases the enzyme renin into the bloodstream to trigger an emergency pressure increase through the RAAS pathway. Renin acts as a catalyst, sparking a chemical conversion that culminates in a massive surge of a compound known as angiotensin II. Angiotensin II acts as a powerful vasoconstrictor. It aggressively clamps down on the entire vascular system, violently spiking the patient's blood pressure even higher. The patient is now locked into a lethal, self-sustaining cycle. Higher systemic pressure causes more nephron damage, which tricks the kidney into releasing more renin, which drives the pressure up again. Left unchecked, this biochemical loop means the kidney will methodically destroy itself in a misguided attempt to keep the body alive. Homeopathic management targets the failing vascular and constitutional nodes directly, moving beyond the simple suppression of systemic pressure. For early endothelial damage and severe vascular stiffness, particularly in elderly patients suffering from arteriosclerosis, the clinical map points to burrita muriatica. If that vascular resistance is paired with a physically weak cardiac muscle failing against the pressure, Crataegus oxyacantha is deployed to support both the heart and vessel walls. When the hypertension is driven by a systemic salt imbalance and deep emotional suppression, acting directly on the volume-driven RAAS loop, Natra muriaticum becomes the indicated intervention. During the earliest stages of renal stress, characterized by erratic blood pressure fluctuations paired with right-sided constitutional and digestive complaints, lycopodium addresses the initial intraglomerular pressure. This intervention treats the vessel walls directly, rather than only manipulating the fluid pumping through them. As the disease timeline progresses, structural damage eventually breaches the clinical threshold, and the filtration barrier breaks down. The moment proteinuria is detected and fluid begins pooling in the body as edema, the therapeutic focus shifts to apis mellifica. If mass nephron loss leads to acute renal failure tendencies, marked by severe oliguria, a dangerous drop in urine output, the intervention scales to serum inguinale. Finally, when the patient reaches advanced chronic kidney disease and deep uremia, presenting with profound physical weakness, systemic toxicity, and intense restlessness, arsenicum album is utilized. The homeopathic materia medica provides an escalating clinical toolkit that mirrors the pathophysiology of the disease timeline. Deploying these specific remedies requires rigorous environmental control. Without strict patient compliance regarding immediate salt restriction and stress management, the biomechanical pressure will simply override the therapeutics. This management also demands exact quantitative monitoring. The efficacy of the intervention must be tracked continuously through objective data. This involves routine checks of blood pressure metrics, serum creatinine levels, and precise urine protein analysis to measure the physical state of the glomerulus. A mild asymptomatic rise in blood pressure guarantees the eventual destruction of the renal architecture if left alone. But by identifying the exact pathological nodes and applying accurate, targeted therapeutics, the progression of the silent killer can be stopped.